Class, welcome. Now we are in competency 12, building through consensus. So building through consensus is part of the domain masterful execution. This is the second competency. We looked into competency 11, generating informal power. So when we hear consensus, we always think consensus meaning I am in agreement with whatever you propose. So here, consensus isn't reflective of everyone nodding in agreement with somebody saying. It's about leaders creating a decision-making process that respect diverse perspectives and build a genuine support for action. So all of these competencies are all about truly the authentic genuineness with integrity, truly connecting with each other. That's the reflective nature of what we are discussing here. So in healthcare, this is often the difference between smooth implementation and a total breakdown. Let's go back to the COVID-19 timeframe. The early months of COVID-19, leadership had to decide whether to convert the entire hospital wings into COVID units. Physicians were worried about resource allocation, nurses worried about safety, finance teams are worried about sustainability. So if leaders had simply announced the decision, the resistance would be high coming from every sector of the hospital. Instead, they brought the stakeholders together. They listened to the concerns coming from each group, and they all came together and co-created a phased plan. The result was not probably everyone got exactly what they wanted, but because the process was transparent and inclusive, the decision carried the legitimacy by which it can be executed. So each leader would then go to their staff. They would present that unified voice where execution or delivery can move forward quickly. So that's the power of building consensus. It doesn't mean avoiding hard calls. It makes decisions that would be fair, that would be inclusive, and people will support it because they felt their voice was heard, their presence was respected, and all of the issues that they brought to the table was addressed during the consensus process. They may not be fully solved, but they were addressed. So as we dive into this competency, always underline this point that true consensus isn't about the agreement. It is about alignment. And in healthcare, alignment is often the difference between burnout and breakthrough. That's the difference, alignment, burnout and breakthrough. So let's go through the framework model. Let's talk about what is building true consensus and why does it matter. So we discussed in healthcare, consensus becomes critical. Why? Decisions have this ripple effect, which will be reflected from multiple teams. Think about a hospital deciding whether to implement a new electronic health record system. So IT wants efficiency, physicians want speed, nurses want usability, and administrators want cost control. So if leaders push the decision without consensus, the rollout will likely be met with frustration, resistance, and pushback. But when consensus is built, when all groups felt that their voices are heard and their needs are considered, the adoption rate will skyrocket. So, a real world scenario comes from Mayo Clinic patient centered redesign projects. Rather than dictating changes, leadership invited input from physicians, they received input from nurses, administrators, and even patients. So, this collaborative process took a longer upfront, but the resulting solution had a stronger buy in. Staff weren't just complying with a new system, they felt that they were advocating for it because they gave shape for it. And that's why consensus matter. It doesn't eliminate conflict, but it transforms resistance into collaboration. It ensures that once a decision is made, people will support it. Not because they have to, but because they believe in it. They preached for it. They brought it to the table. Now they own it. In short, consensus is not about avoiding tough calls. It's about building that alignment so that once the decision is made, the team moves forward together with a shared purpose. So now let's take a look at how effective leaders would be demonstrating this competency. So building consensus isn't about everyone voting for something the same way. It's about guiding the team towards alignment while making sure all voices are heard. So let's take the example of a hospital. A leadership team had to decide whether to invest in a robotic assisted surgery. Surgeons were divided. Some argued it was essential for attracting patients, while others worried about cost, training, support, accuracy, all of those things. So instead of forcing a decision through, the CEO invited structured conversations. They didn't simply count the votes, they weighed the expertise of each stakeholder. Surgeons who had experience with robotics had a stronger voice, while finance leaders they provided input on a long-term sustainability. And by balancing the perspectives coming from different groups, the hospital reached a fair decision, yes to robotics. But faced with clear cost controls so that people who raised cost as a concern, training as a concern, now have a very clear pathway into how that will be managed. Another example comes from nursing unit during the COVID-19 pandemic. The team had to redesign the patient flow very quickly. Time was short, but the nurse manager focused only on the most critical issues: infection control, staff safety, and patient throughput. By cutting through the noise and zeroing in on the key concerns, because the time, the environment, and the decisions have to be fast, she avoided something called decision fatigue. This efficiency allowed consistency to form in days rather than weeks. Highly effective leaders also know the power of open dialogue. I've seen leaders run listening rounds where they sit with different teams and hear frustrations before a policy change is rolled out. One medical director said, "We don't always need agreement, but we need everyone to feel heard." That sense of respect built trust, even when the final decision didn't reflect every individual preference. Finally, consensus is not about being conformity or practicing conformity. Think of it again and again as creating alignment, not uniformity. In one case, a large academic center was considering bringing all of the oncology services under a centralized umbrella. Not everyone agreed to that, but the leadership acknowledged, while still moving forward, let's gather everybody's perspective and make sure that all of the issues are properly addressed. So they didn't resist implementation, they supported it because staff felt that their voices have been heard. So highly effective leaders balance votes with voices, fairness with efficiency, and unity by respecting diversity. So the result is team will walk away with buy-in even if they didn't get everything they wanted because they believe that the process was fair. So consensus is powerful, but it's not always done well. Sometimes leaders fall into trap that turn consensus into a weakness rather than a strength. Let's take an example. In olden days, coming from an electronic health record implementation, the leadership took a command and control approach. They told the clinicians, here is a system, use it. There was no real consensus building. It was top down directives. You can imagine the result: frustration, resistance, months of workflow disruptions, patient care, patient safety, patient throughput, all impacted. What should have been a unifying initiative now became a source for dividing voices of leaders. On the other hand, sometimes leaders try to build consensus but do it unevenly. Imagine a department meeting where one or two loud physicians dominate the room. The quieter nurses and support staff would have valuable insights they want to bring in regarding patient flow and safety, but their voices are drowned out. The final decision may look like consensus, but in reality, it reflects only the loudest opinions. Over time, this creates resentment and disengagement. Another pitfall is when leaders lack sensitivity to the interpersonal processes. Consensus isn't just about reaching an agreement, it's about how people feel along the way. I recall a case where a hospital administrator pushed hard to centralize scheduling. Centralized scheduling and decentralized scheduling is something that every hospital struggled for decades. So the final decision was technically correct, but staff felt this was rushed and it was unheard. So even though they complied, the morale dropped because the process ignored the emotional side of the consensus. Leaders can also go on the other extreme, too far to win the support. So a CEO negotiating a merger kept making concessions to avoid conflict. At first, it seemed very collaborative, but eventually the staff noticed that the hospital's key priorities were being watered down. Too much ground was given, and the CEO's authority was weakened. So consensus shouldn't mean compromising the mission. And finally, when leaders don't fully understand the process of building consensus, they may confuse it with just getting everyone to agree. So true consensus is about balance, but that balance is respecting the diverse views, maintaining the clarity of purpose, and guiding the group towards alignment. Without that balance, consensus can backfire. So when consensus isn't done well, it either feels imposed, unbalanced, overly compromising, or disconnected from the real work. So, in short, the lesson here is building true consensus requires skill. Otherwise, it risks weakening trust and credibility instead of strengthening it. So, now let's go to the third part of the framework: misuse or overuse. So, consensus is powerful, but like any other competency that we have seen, when it is overused or misused, it can slow down progress and weaken the leadership. Let's look at the first trap: being biased towards a universal agreement. Some leaders believe every decision requires everyone's buy in, no matter how small. I remember working in a hospital where leaders insisted every clinical department to agree before rolling out a new patient satisfaction survey. What should have been a simple decision, it took months of back and forth. In the end, the survey looked nearly identical to the original proposal, but the delay of rolling it out, it costed valuable time. The second pitfall is building consensus even for minor decisions. So imagine your chief nursing officer pulling together a task force to decide on the brand of hand sanitizer dispensers. While the intent wants to be inclusive, staff would be rolling their eyes. It wasted their energy and made them less likely to engage as compared to the truly important issues like nurse patient ratios, where there is a thoughtful discussion and decision to be made. The third challenge is when leaders are too eager to avoid disagreement. So conflict isn't comfortable, but it's often productive. I recall a case where leadership team avoided debate on a controversial policy about physician scheduling. They rushed to a watered down compromise just to keep the peace. But the policy failed because no one was truly committed and the resentment lingered. Avoiding disagreement only postpones conflict, it doesn't resolve it. Another misuse is pursuing consensus when it is not needed. Sometimes leaders forget their role in making decisions. Let's take a trauma unit. A medical director held long meetings to get everybody's agreement on shift rotation. The reality, this was supposed to be an operational decision that could have been quickly made with input, but not a consensus. So the delay frustrated staff who just wanted clarity and direction. Finally, there is the danger of wasting time and resources trying to accommodate all views. So in a large health system, you have to know that you will never get 100% agreement across physicians, nurses, administrators, and other staff. So trying to satisfy everyone often lead to the lowest common denominator solutions, which is safe but bland and ineffective. So one hospital board spent weeks debating the design of their new website because every stakeholder wanted a piece to influence. So meanwhile, critical decisions about patient care technology, upgrades that are needed, all of them were delayed. So the key takeaway from all of this is consensus is a tool, not a religion. It works best when used intentionally on the big strategic decisions where buy-in truly matters. But when applied indiscriminately, it drains time, energy, and trust. So now let's take a look at how we can enhance the consensus building. So the best leaders don't just hope for an agreement. They cultivate it with intention and skill. Let's explore how we can enhance this competency in practice. So first, like other competencies, finding the role models, finding someone who does this well. In every organization, there are natural leaders who excel in building the alignment. I remember the chief medical officer who was known for bringing physicians, nurses, and administrators into the same room discussing contentious topics like bed allocation. So instead of forcing an agreement, he listened carefully, highlighted the common grounds, and left people feeling heard. So once you watch, observe such leaders in action, that's the fastest way by which you can build the skill of consensus building. Second, use the structured group techniques. So tools like nominal group technique or affinity mapping, it will help quieter the voices, and it will also make sure that everybody is inclusive. So let's take an example of a hospital merger. This particular situation, leadership used something called as scenario sketching. They asked teams to imagine different partnership futures. It is to bring out the hidden concerns truly coming from culture and patient care. So when you have a structured approach like scenario sketching, it will keep the discussions productive, and it will also prevent the dominant personalities from overpowering the group. Third one is effective facilitation. If you can facilitate effectively, consensus can go in different directions. So skilled facilitators can act as neutral guides, keeping discussions on track, and they will ensure fairness. This is very true, whether it is a workshop or a board retreat where a facilitator used time-boxed discussions and even voting cards to make sure everyone from senior surgeons to junior administrators had an equal say. The result was a decision that was both efficient and inclusive. Fourth is trust and credibility. Consensus cannot exist without trust. For example, when a nursing director pushed for changes in staffing models, her credibility with the frontline nurses, built over years of fairness and advocacy, as we discussed in the previous competency, they trusted her recommendations. So without that informal power, without that foundation, consensus would be impossible. So finally, balancing inclusiveness with timely decision making. It's important to include voices, but leaders must also recognize when to close the discussion and move forward. So during the pandemic, many hospital leaders had to exercise this. They had to balance collaboration with urgency. They sought very quick input, incorporated the essential perspectives, but then acted decisively to adjust the protocols. Waiting for the perfect consensus would have cost lives. So enhancing consensus isn't about endless meetings or everyone agreeing 100%. It's about fairness, structure, and trust. It's about knowing when to listen and when to decide. Now let's talk about what are different opportunities by which you can build one from your personal development perspective. So this is a discipline. You can practice, you can refine, and you can apply in different areas of life, not just in your profession, your personal, in your community, and whenever there are a group of people involved, like a nonprofit organization, so on and so forth. Volunteering in community organizations, you would learn absolutely the power of consensus. I would probably reflect back on my experience working in community organizations, several kinds of board where you're not paid, you are not measured by somebody on your performance, yet you're responsible to run an organization or a department or a company, like a church committee or a local parent teachers association. In all of these settings, diverse voices, competing priorities, limited resources, this can be the excellent laboratories for consensus building. You will learn a whole lot about yourself, build your skills, understand each and every one who you thought were your friend, but have totally different perspectives when they sit around that table. And you will be able to exercise those skills by aligning with the different stakeholders. Second would be the professional development workshops. Many healthcare leaders attend consensus building or negotiation seminars where they role play scenarios and bring out the real tension. I know there was a physician who went through such a workshop and learned powerful techniques on how to de-escalate conflict between surgeons and anesthesiologists, physicians and nurses, physicians and administrators on different kinds of topics. It can be scheduling, it can be supplies, it can be staffing ratios, it can be templates that they use often. So that those training improves that particular department collaborations, whether it's ICU, whether it's OR, whether it's an administrative unit, so on and so forth. Third, there are so many structured decision-making techniques. So tools like force field analysis, fishbone diagrams, all of this can uncover root causes of resistance in groups. Or affinity mapping is another one that you can use for prioritizing initiatives, allowing different viewpoints to come together, remove all of the noises, and make sure all of the key points that have been brought to the table have been heard and incorporated into the new process. Finally, going through the self-study, utilizing resources, and there are so many books in this topic. Decisive by Chip and Dan. They provide practical frameworks for overcoming decision-making traps. How do you narrow down your choices and move forward? So leaders who take time to reflect on these insights can bring different and fresh approaches to their organization, making consensus not just possible, but sustainable. So remember, personal development and consensus, it's not just in boardrooms, it happens when you step into diverse group, engage in training, practice structured methods, and challenge your own thinking through study, reflection, and learning. And every one of these opportunities will prepare you for the next one in how to lead with fairness, how to lead with credibility, and produce an impact that you're looking for. So, as we wrap up our discussion on building true consensus, let's take a step back. Reflect on why this competency is so critical for leadership effectiveness. First, let's acknowledge the challenge. Building consensus is not easy. It requires patience, it requires empathy, it requires relationship building, it requires a willingness to navigate the conflict without losing the sight of the mission, vision, goal, and all of those things. And I can guarantee you, your effort will pay off. Leaders who master consensus creates a stronger commitment and buy-in for the project, for the initiatives, for their department, for their institution. It's simple. Think about it. When people feel their voices were heard, even if the final decision is not exactly what they wanted, they are more likely to support it. So in healthcare, this principle is especially important. Whether you're launching a new electronic medical record system, a new project, changing of existing policies, procedures, if the decision is made in isolation, the frontline staff may resist. They will find workarounds that will undermine what you're trying to achieve. But if the same groups are engaged early, their concerns are addressed, their insights are incorporated, the rollout is smoother and more sustainable. So consensus doesn't just improve the outcome, it reduces the resistance. Consensus also fosters collaboration. We have seen this in pandemic. Many hospitals faced several kinds of challenges, resources, patient intense problems, unknown treatment pathways, supplies, shortage of supplies. So they have to navigate as well as build a leadership consensus across the departments to ensure the decisions are fully thought through, fair, balanced, and that can take the hospital sustained during those days. So this opportunity pretty much brought the siloed team together. It strengthened the trust and allowed them to act quickly while keeping the teams united. Finally, The hallmark of exceptional leaders is the ability to balance inclusiveness with decisiveness. Too much inclusiveness without action can stall progress. Too much decisiveness without inclusion breeds resentment. The leaders who stand out are those who know when to listen, when to negotiate, and when to move forward confidently. So, the key takeaway is this: building true consensus is not about forcing agreement or avoiding conflict. It's about creating alignment, strengthening the commitment, and ensuring that your initiatives have a long term support, and making sure that you would be able to live with with an ecosystem which are truly supportive, one who understand that transparency, fairness, equity are all balanced, because these are all interconnected. So this skill is not just valuable, it's an indispensable skill to learn, to practice, apply, and learn from there. And then you would become, over a period of time, you would develop the necessary muscle to build this competency by which you can execute this like an exceptional leader. Thank you, class.